So this is a 68 years old patient who is a known chronic smoker, alcoholic diabetic, and he underwent the angiography, coronary angiography before the 5 years, as he had unstable angina at that time, and that coronary angiography showed mid segment of LAD CTO, as you can see in this present angio. So he now presented with the CAD and STEMI and with effort angina, and you can see this is the mid LAD CTO, and distal LAD you can see clearly, and there is a chronic total occlusions in the mid portion of the LAD in this apicaudal view. And you can see there is a in this you can see there is a clearly you can see the proximal cap that is almost blunted or tapered. It is an unambiguous proximal cap, and distal vessels you can see, and you don't see any interventional collaterals. So basically IGCTO score was like 1, and we decided to go with integrate wire exclusion techniques to do the angioplasty with this patient. So at that time when they did the angio 5 years back, they deferred the case and was given the option for the CABG, but then patient was not willing for the CABG. Now they have come with this, so we decided to open this artery, and we decided to go with the antegrade wire exclusion therapy, and if it is not possible, then we will go with the antegrade dissection and re-entry strategy. So now we decided to go with the antegrade wire exclusion therapy. So this is the apicaudal view, and you can see this is the blunt end, and this is the distal. This is the portion of the CTO is almost around 30 mm portion, and this is the distal portion which is flowing with the collaterals, and is the portion is almost, and this is the aleocranial view, and you can see in this aleocranial view the other arteries are good. There is no lesion in the other arteries. Only what we could see is the CTO segment in the LAD, and obviously we cannot see the microchannels. So this is the distal segment of a LAD which is flowing well, and with this septal collaterals, and this is the portion of a CTO, and from there to this is almost around the 30 mm segment of a CTO, and we don't know whether there is Iceland of a normal flow in between, or calcification, or only fibrosis. And this is the ariocaudal view, and this is the aleocaudal view, and you can see this is the distal flowing of LAD, and in this still frame image you can see this LAD has to go like this, and this is septal, but LAD has to go like this, and you can see the flow in the distal LAD. So this is the aleocaudal view, and then we started with this is the distal portion of the LAD that has to go, and this is the lateral view, and you could see clearly here the stump there, and that is unambiguous cap, and you can see, and this is the distal portion of the LAD which is flowing well, and this is the mid portion of the LAD that has a CTO. So clearly you can see in this lateral view this portion, proximal cap of the CTO, and this is the mid portion of the CTO, and this is the flowing LAD with the septal collaterals. There is a good flow, and then we started with microcatheter and wire, and we started with directly with Gaia 2 wire, and this is microcatheter and Gaia wire, and it was very difficult to cross, and we decided to start with the Gaia 2 wire, and this is a microcatheter and this is wire, and there was a many hurdles because this portion we had to cross, and then we had to meet in this distal segment, and there was a septal, there was a diagonal, so wire were going here and there. So we don't know the path, and then we started with this GAIA2 wire, and we decided to puncture with this wire. And earlier we have done the CT coronary angio to see the any calcification, and then we progressed the wire with the GAIA2 wire with the microcatheters, and then we succeeded in crossing the proximal cap with the help of GAIA2 wire, and then we exchanged the wire with the whisper. And this is a wire you can see that once we cross the we punctured the proximal cap, then we exchanged the wire with the whisper, and we have to cross this again. And then now the things are like I was progressing the wire. This is the wire, and you can see the entry of wire. I was pushing the wire with a small rotation for giving the directions, and you can see the tip of wire. Whenever it was a buckled wire, then I removed the wire, but then somehow after some time, after an half an hour, I crossed the lesion in the CTO, and you can see the wire end. As soon as the wire buckled, I removed the wire, and then I checked in the all other views, and then I was whether I was in the correct lumen in the tract or not. And then after some half an hour we crossed the lesion, and you can see in this lateral view I crossed the lesion, but there was a long way to go. So with this whisper wire only I crossed. We punctured with the GAIA2 wire, and then progressed with the whisper. So now I crossed the CTO segment, and then I entered in distal cap, and then I succeeded in crossing the CTO lesion, but there was no flow in that segment. And then I started to do the predilatation with the balloon is 1.5, and we have done the balloon daughtering 1.5 balloon, 2 balloon, 2.5 balloon, and after some half an hour we got the flow again. And this is the flow we have got at this time, and this is the again AP view, epicranial view, and you can see we got the flow. And then we put the stent there, 2.75 stent into 32 in the mid distal portion of the mid part, and then proximally we have put the 3 into 40 stent, and then we did the overlap. And then you can see the wonderful opening of this LAD. This was LAD CTO, and you can see the wonderful LAD opened. This is the CTO, and this is the elevocranial view, and you can see how wonderful that has opened up. So this was a very complicated case. We have punctured with the GAIA2, and then we progress with the whisper wire.